All right, hello, good afternoon. So I'd like to take a moment and thank the organizers of ADA's Innovation Hub for inviting Skye to present this day today. My name is Chris Twitty, I'm the Chief Scientific Officer at Skye, and the focus and title of my presentation today is Mechanistic Insights into Weight Loss and Metabolic Regulation of Obese Mice Treated with Nimacimab, a peripherally-restricted CB1 inhibitor. I'm just going to move this table here. Okay, just jump into a quick background. This is CB1, and specifically peripheral CB1 as a metabolic-focused target. So cannabinoid type 1 receptor, CB1, is distributed throughout the periphery in different tissues and organ systems. Engagement of CB1 happens through endogenous ligands, endocannabinoids. And interestingly, these endocannabinoids are regulated. So in fasting states or in obese states, you can see that these endocannabinoids are regulated, and this increase of this axis drives many different things, including changes to energy homeostasis. And this can be manifested as shown here in the adipose tissue, increase in triglyceride accumulation, reduction in lipolysis, inflammation and associated fibrosis in the kidneys, as well as lipogenesis and blunt insulin signaling in the liver and pancreas, as well as GI motility and increase in appetite, regulating hormones in the digestive system. So inhibition of CB1 certainly could play a role as a metabolic therapeutic, and this in fact was shown about 20 years ago with some CB1 small molecule inhibitors, notably rimonabant and taranabant. Fortunately, those small molecules readily penetrated into the brain, inhibiting CB1 and causing unwanted neuropsychiatric AEs, and these programs were discontinued, as I'm sure all of you are aware. So more recently, some companies are developing second-generation small molecule inhibitors that are certainly better in terms of its restriction in the periphery, but we are still seeing that these small molecules have some hurdles to contend with, notably still penetration into the brain. So at Skye, we're taking a different approach, and we're actually using what's called Nimacimab, and this is a peripherally restricted CB1 inhibiting antibody. So Nimacimab has a long half-life. It is excluded from the brain. Almost, we'll get into that data, but it's orders of magnitude more than even the current second-generation small molecules that are in the clinic today. And this certainly is a differentiated inhibitor, not just from its distribution, but also the way it interacts with the receptor. So like the small molecules, it does function both as an antagonist as well as an inverse agonist, but it does this in a non-competitive fashion. So we have a slide that addresses some of that. Overall, we feel this is a very safe and effective drug. It's using our own PK data from phase 1 trial. We're seeing in our current clinical trial that we're more than 8 times the concentration needed to inhibit CB1 in the periphery, yet we're more than 600-fold below that concentration in the brain. And so this, along with a non-competitive type of inhibition, collectively creates a favorable therapeutic index, which we think will lead to a safe and efficacious therapeutic to treat obesity. So just jumping into some of that biodistribution data, this is 3 independent non-human primate studies that we did, all kind of looking at this in a different way, whether it's through a weekly dosing or a higher dosing at 40 mg per kg, and even a labeled Nimacimab to do the PET imaging scan. You can see that the thrust of all this data is that there is minimal accumulation and almost no Nimacimab detected in the CNS or brain, and this is often at or below limits of detection. So when you couple this with no behavioral changes in our tox animal studies, along with a really strong phase 1, so more than 60 patients dosed in the phase 1 trials with no psychiatric effects, I feel this is a very safe and again very much a peripherally restricted therapeutic. Jumping into one other key differentiator before we get into the DIO data. So this is just a cartoon that helps emphasize the type of binding. So draw your attention to the upper left cartoon. Here we're looking at CB1, and in the yellow circle, this is the orthosteric site where the endocannabinoid, in this case, with 2-AG or anandamide, these endocannabinoids bind at the orthosteric site, as does the small molecule, in this case representing monlunabant. And so there's competition for that orthosteric site, and in a more physiological setting, represented here at an 80% activity, it's quantitative at 50 nanomolars. You can see it's quite active and typically win that competition. But as you increase the amount of endocannabinoids, You can see below that the curves distort, and this is quantitative below, to show more than 100-fold reduction in its potency. And this is different than the Nimacimab on the right, where you can see it interacts at an allosteric site away from that orthosteric site, so the endocannabinoid can freely bind. And this does not seem to impact the curves, whether at a lower or much higher concentration of endocannabinoid, or in this case agonist. You can see only a 1.6-fold reduction in potency. So this, along with the biodistribution, really speaks to a differentiated approach to CB1 inhibition. I think something on everybody's mind, including ours, was, can we manifest weight loss with this differentiated approach? And so we built out a DIO model to answer that, looking in mice, diet-induced obesity model. And our first study did show, in fact, a dose-dependent increase in weight loss. You can see at the 75 mg per kg dose in dark blue here, 60% weight loss. This was associated with productive body composition. On the right, you can see this is driven mostly by fat mass with relative lean mass preservation. We included a suboptimal dose of semaglutide in this study. This was dosed day 3. This is in line with what other publications were showing. And in the next study, and this is important because this is the first time that Nimacimab had really shown to be, or any type of restricted inhibitor of this nature has been shown to create weight loss. We want to make sure that we had it right. So when we looked at a repeat study here, independent lab, we saw very similar results. Now the model itself is a little bit different in that we did see an increase in the vehicle control, but the overall magnitude is very much in line with what we had showed in the initial study. Here's a more active dose of semaglutide. You can see that in the end they're both very similar in terms of magnitude of weight loss, and again the body composition echoed what we saw in the initial study, with predominantly fat mass being the driver and relative lean mass preservation. Now, plug into some of the mechanisms that could be driving this, and of course the first place we looked was at the idea of caloric restriction. And in fact, we are seeing that both semaglutide, as you would expect, as well as Nimacimab, have significant reduction in the caloric intake. You can see that on the left with the cumulative food intake graph. Also on the right, when we look at the relationship between daily average intake versus body weight before and after therapy, both point to that. So this is a really interesting result. And when we think about this being such an excluded, this is a really peripheral mechanism, how could we get this type of anorexigenic effect? And one of the areas that we're investigating is modulation of hormones that can happen in the periphery and sort of connect the circuit back up in the central compartment. So we see this, in fact, when we look at some of the key hormones, particularly at the higher dose of Nimacimab on the left, we can see that GLP-1 is in fact increased. And interestingly, we see in the middle panel here that leptin is coming down. And so hyperleptinemia that we're seeing in this DIO model commonly, and certainly some of our patients in the clinical site probably also contending with hyperleptinemia. So control of leptin levels is really important. I think the first step of getting productive insulin signaling happening. And so we're looking more into that, but this is a really important hormone that we're seeing here modulate. On the right is resistin. This is also a really interesting hormone associated with adipocytes, particularly associated with type 2 diabetes, but certainly plays a role in obesity. So collectively, this is something that's very interesting, this idea of modulating the hormones as a way to connect the circuits. We're also looking at potential interaction with the vagus nerve, as well as areas in the hindbrain and hypothalamus, potential interactions outside of the blood-brain barrier that could also speak to amplifying the reduction in food intake. So another mechanism that we followed is improvements in glycemic control. And here, if we're looking at fasting states of both glucose and insulin, you can see that there's nice modulation, reduction in the fasting state of both glucose and insulin with the Nimacimab treatment. When these fasted mice are introduced with a bolus of glucose on the upper right, you can see that the GTT does enable nice reduction in blood glucose over time, and this is quantitated below in the area under the curve analysis. So we do believe that there's a nice improvement in glycemic control. Pair-fed mice are being set up with the next study to really help understand the potential indirect weight loss effects as it might impact these glycemic controls. That work's underway. The next mechanism that we thought was of interest is to understand lipid metabolism, and this pathway is known to promote enhanced lipid metabolism. And when we look at the liver of these mice, we can see, in fact, that there is improvement specifically in the steatosis. So this is a blinded analysis on the left. Pathologists read the HME, some of the representative H&E images here. And you can see on the far left, this is a controlled diet, healthy, normal weight mouse with very little steatosis. So the light pink, as you move into severe steatosis, dark red. The vehicle control is, as you can see next to that, a lot of steatosis there. And all the way to the right, semaglutide does a decent job of controlling steatosis, but not to the same level as the higher dose of nimacimab, second from the right. This is actually quite striking, the level of improvement. We see the same thing happening when we use a computer scoring to sort of look at these areas, and you can see in the graph to the right the same type of data with higher doses of nimacimab controlling steatosis. Interestingly, we also saw a reduction in serum cholesterol with the higher dose of nimacimab. So we do think that lipid metabolism is a key mechanism in terms of the overall driver of nimacimab efficacy. So the last component, again, these are all sort of coordinated mechanisms that we think are at play, is around the obesity-related inflammation. And so if you look at the liver, we're seeing that there's certainly a change in fibrosis, and this may be driven, in fact, by the macrophage density that's also coming down in this compartment, in this tissue. And when we look below this at the white adipose tissue compartment, we can see there's a reduction in an adipocyte area, kind of the same for nimacimab and for semaglutide. But if you look to the right, the density of macrophages are notably different compared to semaglutide. So we do think that this pro-inflammatory or myeloid immune subset may be playing a role, and certainly has been described that way in the publication. And finally, to the far right, when we look at serum inflammatory markers, this is a cytokine array, pooled samples, so sort of an exploratory endpoint. We're looking more deeply into this, but this data, I think, gives us some directional sort of clues that there's multiple immune pathways at play, whether it's a Th1-related response with IL-12 and TNF-alpha, or even the Th17-based IL-23 type of modulation, even complements in play. So we're digging more into this, but we certainly feel that reduction in obesity-related inflammation is a key player, whether it's directly weight loss or more supportive or more productive. The immune set point or metabolic set point likely to be at play. Now, just wanted to finish with this last study. We certainly saw that there's some overlap, particularly around the anorexigenic drivers, but some of the mechanisms support an orthogonal approach to this nimacimab-driven efficacy. And we thought that combining with tirzepatide may allow for some additive effects. So in this study, we compared nimacimab either as monotherapy or in conjunction with tirzepatide. We also included monlunabant. This is a small molecule inhibitor, second generation, Novo's developing. As a quick aside, we're using active doses in this study of both monlunabant and nimacimab. So this is monlunabant dose is in line with the phase 2 20 milligram dose, and nimacimab with kind of a higher load phase before moving back to the 75 mg per kg is really translatable to what we're doing currently in the clinic. This is certainly a suboptimal dose of tirzepatide, and you can see, however, all three of these sort of end up at about 22-23% weight loss. Interestingly, the combination of tirzepatide with nimacimab provides over 30% weight loss. So we're pretty excited about this initial data. We're certainly looking deeper into the combination maintenance strategies. We'll have more data to share with you folks in the next few months, but this is an interesting start. And the last piece I finished with is just extending this day, looking at the quality of the body composition. So like the previous studies, we're seeing that fat mass is the driver, lean mass preservation. There's a trend, not significant, but a trend towards increased fat mass loss in the combination. And interestingly, we're seeing that thermogenesis in the brown adipose tissue with the nimacimab is increased. And this is something that CB1, a lot of different preclinical studies have talked about, just energy expenditure globally. And certainly when you think about mitochondrial density, uncoupling proteins, and thermogenesis sort of in that same category. So we're looking more into this. I don't know if this is necessarily a driver, but it might fit into the enhancement in lipid metabolism. So we're looking further at this. So just to summarize and bring it back home, so nimacimab is a humanized anti-1 antibody, and there's some key differentiators there. We talked about the restriction and the way that it interacts with the receptor. We think that's very unique. This might be very important in terms of how it interacts, especially in the face of elevated endocannabinoids in the clinic. The efficacy is certainly there. We're seeing that as a monotherapy, potentially even in combination. This is being repeated independently, so we feel that this data set's pretty robust, and we're doing it's more and more with these models. We see a very similar efficacy as it relates to monlunabant and semaglutide, and again, the combination is something we're very much focused on now. The drivers, we think, relate certainly to the reduced caloric intake. I think this is happening in part through modulation of the hormones that's being explored further. And then we see improvement in the glycemic control, lipid metabolism, and potentially energy expenditure, and reduction in obesity-related inflammation. So thank you all for your attention. The team is back here if you want to find us and talk to us. I'm happy to take any questions. And if you think of something down the road, that's my email address. Feel free to reach out, and I'm happy to answer any questions. Energy expenditure? Yeah. So we actually have a dedicated study to measure that properly, metabolic pages, etc. So we haven't done that. The closest would be really just touching that thermogenesis data. That's the only real piece that would speak to that. But it's a great question, something we're looking at. We haven't done it properly. Expect it to be there to some extent. Yes.
Yeah, thanks for the talk. I understand that this asset is entering phase 2. So could you share any findings in the phase 1 on both the safety and efficacy, especially the weight loss if you measure?
Right, yeah. So we actually were accepted for oral presentation. So anybody here going to EASD, there's going to be a deep dive into that and speak more to it. And our CMO is back there who can really dive in. But what I can tell you is this is really, the phase 1 was a SAD MAD. So 28 days in a NAFLD population, diabetic, pre-diabetic, so probably not the best metric to get believable weight loss. We did see some interesting signal there. So there was some placebo-adjusted weight loss that was, I think, in line with what maybe some of the early GLP-1s might see in that same population. Some biomarkers, LDL quickly was moved around in a productive fashion. But overall, small signal, what you might expect with that population, and particularly with that time frame. Our current phase 2 is a longer trial. We think with this mechanism, we see that there's a little bit more time needed to get that weight loss. It doesn't behave like an incretin with that faster, pronounced weight loss, or even some small molecules. It's a kind of a slower type of weight loss. So we have a little bit more time. 28 days probably isn't the best way in that population to measure that efficacy. Good question, though.
In your preclinical model, you use quite a high dose, 75 milligrams per kilogram. What dose do you expect in human? The active dose in human you expect?
Yeah, we're dosing 200 milligrams flat dose, and it's true. So after doing these initial studies, we went back and sort of did a careful PK analysis, and in fact, our half-life in these mice is quite short. So we've been translating the dose not based on allometric scaling, but really looking at exposure area in the curve analysis, and sort of as you might imagine, kind of a high Cmax and a quick clearance. So the area under the curve really does translate back to what that 200 mg flat dose is.
So CB1 receptor, right? Did you check any kind of behavior activity related change in this kind of mice? This is phase 1. Second, so for this receptor, what's the major tissue organ expressing?
So what was the last question?
Yeah, the major tissue organs for this receptor expression.
For expression of CB1?
Yeah, first question is the behavior activity change.
Yeah, so we haven't done there's behavioral tests like open maze, and you can look at, probably the most telling is that in our tox studies, we'll talk to some of the technicians there who actually had done work with some of the early generation small molecules, and there you can really see clear behavioral changes in the non-human primates that were dosed with these small molecules. It was clear, even when blinded, that there was seclusion and obvious a difference in behavior. We didn't see that with the Nimacimab. Now we haven't done that, repeated that in the mice with the open maze or any of the other type of behavioral endpoints. I expect that to be very much in line with what Novo's monlunabant showed. There's a difference in the monlunabant, and we're even more skewed. So It's a fair question, but I don't expect there to be any surprises. In terms of the distribution, I think was your other question, of CB1 and peripheral targets. Yeah, certainly the most expression is in the brain, in CNS, but it's fairly even throughout. So you see it in liver, you see the tissue that we highlighted here, also in the muscle, a little bit in the heart, but overall, relatively equivalent expression throughout most of the tissues.
So the assumption is that because this is monoclonal antibody doesn't go in the brain and will not have the side effects that's known from the CB1 antagonist or blocker that was like many years ago stopped.
Yeah, sorry, what was the question?
The previous CB1, let's say blockers, which was small molecule, was taken off the market because people committed suicide.
Right.
Okay. Why this will not have similar effect? Because it doesn't go in the brain or what?
Right. We think that's the biggest differentiator, is that it's almost exclusively peripheral in nature. Even the second generation small molecules, which I would argue are a huge improvement, are quite interesting. Even then, there is at the higher doses, particularly some engagement in the brain. And it's different than what we're seeing. We're at 600-fold below that level of engagement in the brain with our PKD. There's one over. Okay, last question.
Hi. Have you done anything about rebound effect where you withdraw and look at what happens when you have a CB1 with or without Wegovy or tirzepatide?
Yeah, that's a great question. We just wrapping up that study. We almost put it here, so I can't really speak to it, but we're pretty happy with what we're seeing, and it might speak to some of the mechanisms that are a little bit different, the orthogonal mechanisms that might be that might allow for a more lasting metabolic change. And so we think that metabolic reset can elongate, and we'll have some data to share with you guys. That's a good question. Awesome. Thanks. Thank you all.